We're really pleased today to have you, Dr. Raed, for this lecture series of PM&R in Focus. Dr. Raed is a PM&R consultant and the head of the brain injury program in KFMC. Please, if anyone has any questions, write your question in the comment section, and we would like to keep this one interactive. Dr. Raed, you may start if you wish.
Thank you all for joining today, and thank you for accepting to start the presentation earlier than 7. I do understand that it's more convenient to stick to one schedule, and thank you for accepting my request to change the time. First of all, I'm honored to be speaking to all our consultants here in this webinar. And I do want to say I'm really humbled that you asked me to present to you my humble experience in the brain injury. I would give a small introduction about who I am. So I'm your brother, consultant, Dr. Raed AlAngari. I'm a consultant in physical medicine and rehabilitation. I graduated in 2015 from the Saudi board of PM&R, and I got my brain injury fellowship at around 2018, 2019. I came back in 2020, and I started my journey in brain injury rehabilitation program as Deputy Brain Injury Program Director, and then I became the Program Director of the Brain Injury till today. And I would start my presentation. My talk would be a little bit concise, and I really think you would appreciate that I won't take a lot of your time today. All right. So, hello everyone. I will be talking about brain injury rehabilitation evidence versus clinical experience, my clinical experience in patients with disorder of consciousness and the use of neurostimulation. Good afternoon and good evening, everyone. Thank you for being here. Today, I wanted to address a critical and often overlooked aspect of brain injury rehabilitation, which is the use of neurostimulants in disorder of consciousness. In short, it's called DOC. And we'll be talking about patients with memory consciousness and prolonged unresponsiveness, those caught in that liminal state between coma and wakefulness. And we will be talking a bit about the neurostimulants, when to medicate, when to start, switch, discontinue, and a little bit about prognosis and recovery duration, and we'll allow for Q&A. So in disorder of consciousness, when to medicate, we want to be clear about the definition. So we want to say that the disorder of consciousness is a spectrum, and so it starts with coma, i.e. no wakefulness, no awareness, and then patients go to the next state, which is the vegetative state, and now the the correct nomenclature for it is unresponsive wakefulness syndrome. So it's easy to know that what happened, the no wakefulness became wakefulness, but he's still unaware, unresponsive. And with wakefulness without awareness, we should understand that these are what we anticipate as a state of prolonged and uneventful state where it is a patient who does not have the potential to be responsive to any rehabilitation or any triggers. When we go to an image-conscious state, which is an inconsistent but reproducible signs of awareness. And that's why in mimic conscious status, we could be speaking about patients who perceive but unable to respond to stimuli, but with evidence of what we can say reception of signs of awareness. In these states, the traditional new rehab tools often fall short, and it brings us to the use of, or if we can, use the standardized assessment of the coma recovery scale revised to assess the degree of the coma the patient is in. So when we talk about neurostimulants, the idea is simple. If the brain is structurally intact but functionally underactive, can we jumpstart it? And what we mention as medications mentioned in the table in front of you are only examples of what we can do, but we try to make it as evidence-based as possible, and we are only talking about what is possible nowadays. Neurostimulant target systems involves in arousal and attention. So we mainly work on the dopaminergic, noradrenergic, and cholinergic pathways. Common agents include amantadine, methylphenidate, modafinil, bromocriptine, and sometimes we use zolpidem for paradoxical effect. And each of these act differently, but the goal is the same, is to push the brain towards functional reconnection. All right? So some patients may improve with trials, and we do want to say that there's a window of trial that most literature have spoken about, starting from the 2012 published in New England Journal of Medicine by Giancino, and then the Cochrane review done in 2022 that shows that amantadine significantly accelerates the functional recovery in patients with disorder of consciousness after traumatic brain injury. And this has been a double-blind placebo-controlled trial, and the effects are within 4 weeks. Second to that, we have the methylphenidate, which is commonly used in ADHD patients, and it shows promise in small studies in improving attention and speeding up, specifically in cases where patient is in mimiconscious status. And the data are limited and mixed still with the use of methylphenidate in vegetative state or in coma states. When we talk about other neurostimulants such as modafinil, it has anecdotal support to help in fatigue and hypoarousal, but again, we are lacking the data to support it. And then we have zolpidem, which is a sedative. And why does a sedative being used as a neurostimulant is because of its a paradoxical increase in arousal in some patients. And so it is part of a trial that we use in some vegetative state patients, wherein shows a temporary improvement after a single dose that patients and families say it's a little bit dramatic, where it is a sudden awakefulness. But because of its limited window, it is not unreliable or a medication that it can be used as a chronic neurostimulant. All right, so let's begin understanding the mechanism and the biomarkers. So we try to, as much as possible, look at those patients, most importantly, look at their neuroimaging EEGs, and look at what if they have a preserved thalamocortical connectivity. I want to repeat, we have to make sure that patients have a contact thalamocortical connectivity, and this is the most beneficial way to know whether a stimulation, where it acts on the thalamic pathways, reach the cortical pathways for arousal. Right? So this is one thing. The other thing is to know whether the EEG supports that there is a brain activity and good connectivity. Sorry, just to end up my this slide with talking about limitation and cautions. So we want to make sure that we are realistic when we talk about the common side effects that might occur from those neurostimulants, and they are very variable and sometimes might complicate recovery. And one of these side effects that might complicate recovery is actually hypertension that might cause intracerebral bleeding, or we could have patients with increased insomnia or agitation, or may even reach the level where patient has seizures or abnormal movements. And the only evidence that is available and being used is on TBI patients and not anoxic brain injury, because of the limited number of cases and because this is not a magic pill scenario. So we have to calculate carefully the potential benefits versus potential harm. And what we need to do is to increase the RCTs in non-traumatic disorder of consciousness before we can go and suggest anything. And whenever we want to say we want to do a trial of neurostimulants, we have to have two more very important components, which is an active neurorehab to help make benefit of what the patient is having right now. For example, therapy for disorder of consciousness, or we also need to have other neuromodulations, such as TDCS, transcranial dark stimulation, or even transcranial magnetic stimulation as a adjunct therapy. And in some scenarios, those three would help reach the goal that we want to reach. So let's start with a practical protocol for amantadine, for example. So it's the best studied option. According to the study in 2012, it significantly accelerates functional recovery after traumatic brain injury, and the double-blind placebo-controlled trial is a very rare thing in the field, to why we have chosen this medication, and the effects are seen within 4 weeks. And we start with a medication of 100 milligram daily, and we try to titrate up slowly. Now, the dose of 100 milligram daily can be even lower with 50 milligram in cases where you want to take the surface area or the weight of the patient into consideration. Also, in patients with high risk of developing complications, such as those patients who already developed an intracranial bleed, or those patients who have risk of seizure, higher risk of seizure than others, we might go slower. And we start with 100 milligram daily, 50 to 100 milligram daily, and we titrate up to 200 milligram twice daily. We monitor for agitation, insomnia, hallucination, and blood pressure, and also we should monitor for other symptoms, such as abnormal movements, that we want to confirm whether this is an abnormal movement that is originating from the basal ganglia, or it's an abnormal movement such as other thalamic areas, or it could be an abnormal movement such as a seizure. Then we evaluate for after 4 weeks as a protocol, and there we can decide whether we discontinue or switch if there is no objective improvement. Other weaker evidence, when we say our weaker evidence does not mean that it is not on the table as an option we can use. And those medications are methylphenidate, which may improve in attention and alertness. And it is commonly used in ADHD, as you know. It improves attention and processing speed, but there are limited data and mixed data about them. And we talk about this when we want to mention what are the other clinical importance is that methylphenidate, according to the experience that I have started patients on, have a higher risk of developing seizures and agitation than amantadine. But I leave that, to a more studied protocol to make sure that we do cover all ages, and whether these are more of adult, elderly versus young population, there might be difference in the response, also the side effects and adverse effects. Other medications such as modafinil that helps in fatigue and hypoarousal, but lacking large studies. We also have case series in bromocriptine, levodopa, but limited data. And we need to choose the medication, or this is like a clinical pearl, choose based on specific goals. And when we say that, it means that where are we, at which level in the coma recovery scale? Are we having a patient who is in a vegetative state that we want to go into minimally conscious state? So we have two options. Either we use an amantadine or a methylphenidate. Or maybe we have a patient who is already in coma and we're still in the window of trying the medication. We can use amantadine and lesser to methylphenidate. Or maybe the patient has a sleep-wake cycle where we can add other medications to help in the weak sleep-wake cycle, such as modafinil and zolpidem. Daily practice tips: rule out co-founders such as infection, metabolic, AEDs, and sedation, antiepileptic drugs and sedation. All of these may have been the reason why patients have not emerged so far. Document best pathway for command, whether it's verbal, visual, tactile, motor. What is the actual best response to command the patient is having? Educate family that medication accelerates recovery but does not change the prognosis. And you need to reassess weekly with a standard scale. This is a stepwise like a guide that we can use to go through managing disorder of consciousness. So we need to confirm the diagnosis first. that it is either minimally unconscious state or unwakefulness syndrome, or it's just basically cognitive impairment. Rule out co-founders such as sedatives, infection, and seizures, which if patient is on, we need to treat first, or reduced medication as the safety margin allows us. And we have to establish a baseline common recovery scale or tool or similar tool before starting to initiate amantadine, 50 milligram to 100 milligram, going from once to twice daily, titrating up to 200 milligram twice daily, and we can increase the dose from 2 to 3 days, every 2 to 3 days. We have to monitor for side effects such as agitation, insomnia, hallucination, what I mentioned before. Assess for improvements after 4 weeks, and then try to maintain the dose if patient shows improvement. Extend the trial or increase the rehab if there's a partial response. Switch therapy if no improvement or side effects are intolerable. And consider the alternative, which is methylphenidate, modafinil, bromocriptine, levodopa, and transition therapies by tapering the amantadine and then introducing a new med. Now, one of the key marks that we really do say that at the current state, we say avoid multiple stimulants unless clinically justified. And when we say this, we mean that some medications do provide stimulation while we are giving the patient his own stimulants. And then we need to understand that these stimulants has a synergistic effect and sometimes a counter-synergistic effect, which is affecting each other's response. So doing one medication at a time is safer, but if there's a clinical indication, we should start. We should continue on or try multiple stimulants. Discontinue treatment if there's no benefit after 4 to 6 weeks, and you can discontinue and document if there are severe adverse effects occurring, and these adverse effects sometimes does delay the recovery or unfortunately has a counter effect on recovery. We said monitor weekly and reassess 3 to 6 months for treatment updates, meaning that after the trial, if the patient is not significantly improving, we should complete a maximum of 16 weeks, and then hopefully we can reestablish the case again. Okay. So in prognosis recovery, we talk about usually the fastest gains in any traumatic brain injury. Usually it's between 0 to 6 months, and there are still continued improvement, 6 to 18 months. And patients may progress up to 5 years in severe cases to a very gradual improvement. And this is what we counsel families. We say recovery is not linear, and we have to reassess goals regularly. I think everyone, or I mean, most of us know these points. But if we delve into the prognosis in acquired brain injury patients and how the family has expectations, we sometimes do find ourselves need to be careful what we say or how we deliver the prognosis. So why does prognosis matters? Is because, currently when we want to guide goal setting with families and teams, we have to be realistic about our goals and what we can achieve. And a lot of rehab intensity and family expectation of intensity does not correlate with the current patient status. And then we need to know how much resources we're going to give to the patient. Are we going to go full on doing all resources, or we're just going to focus on those windows of improvement and work on that, then go on and use the resources logistically? And a lot of these prognosis impact the return to work and community reintegration plans. As well, family have medical legal implications, patient or other medical legal implications that is very, very important few months after injury. Most patients and family do want to address this issue, as unrealistic expectation does not allow them to work beforehand in getting patients benefit. So if we talk about the Glasgow Coma Scale, it is, although it is limited, it remains the most strongly early reliable indicator. And more importantly, the duration of coma and unresponsiveness strongly predicts outcome. For example, a vegetative state persisting beyond 1 month of TBI, while 3 months in anoxic brain injury, has different vocab. So we can't say someone is persistent vegetative unless he passed 3 months after anoxic brain injury or 1 month after TBI. And that correlates with a poor recovery and also lesser expectation. And the longer the patient remains in minimally conscious status, the lower the probability of functional independence, but necessarily of meaningful recovery, meaning we do understand that the functional independence, which is the realism, what actually the family wants to know, is when can he become independent. So if someone is in a minimally conscious state, he's probably having a chances of functional independence lower than others, and we need to address that. Okay, so what do we know about TBI and anoxic brain injury? We know that traumatic brain injury generally has a better prognosis due to focal damage or potential neoplastic recovery. We also know that traumatic brain injury, in contrast to anoxic injuries, have preserved basal ganglia and cortex, which anoxic brain injury have them knocked out usually. And the severity increases as it's widespread and has more deficits. And we do understand also that anoxic brain injury rarely recovers to full cognitive function, even if physical recovery is better than expected. And we do rely a lot on not only the bedside exams, which we have, but what other data that is provided, such as MRI findings, functional imaging, and EEGs, to help gather information. For MRI findings, we want to know if it's a diffuse axonal injury, brainstem lesions, bilateral thalamic damage, which suggest worse outcomes. Versus, or on the contrary, we also wanted to see if there are functional imaging, such as functional MRI and DTIs can show preserved connectivity in patients who are unresponsive. EEG patterns that are now gaining traction as early biomarkers to know if there are reactivity and there's intact sleep architecture. These tools are especially helpful in identifying covert consciousness. meaning consciousness beyond observation, and refining prognosis in ambiguous cases. Clinical assessment scales, coma recovery scales, and so on are important in monitoring signs of awareness. Disability rating scales and functional independence measures are for longitudinal tracking. And the Glasgow Outcome Scale is just an outcome certification, meaning it's just a description of what a patient has reached and became. And to us, it's just an assessment tool rather than a prognostic factor. There are two studies that worked on prognostic models, which is the impact and the crash models. And they predicted the 6 months mortality and the unfavorable outcome. I do recommend that you go. It has an algorithm that helps you guide you through the expectation of recovery. But still, it has limitation due to its poor accuracy in some individuals, and we cannot capture all the late recovery potentials. It's a tip that use it as a guide, but not an absolute prediction. Let's talk about clinical predictors of better recovery, younger age, shorter duration of coma, of course, lesser severe initial GCS, early command following, especially if it's motor, higher rehab intensity and family support early on, and the absence of major comorbidities. And when we talk about, although it might be obvious what we mentioned, but be careful when you mention older age. Because most patients who are older age with multiple comorbidities and have low pre-injury independence have to have multiple factors before we can say that likelihood of functional recovery has reduced. Don't mention only age, although age do have a lower, prediction factor, but you have to add more factors to address the chances of lower recovery. Because recovery in older adults sometimes is enough and meaningful for the family because of what they expect. So, the younger the age, the more devastated the prognosis than the older age. If you understand, or we can discuss this maybe in the Q&A. And the earlier the intervention with older age, that's the factor that we want to work on more than looking at the factors alone. So it's not the only contraindication to be in a rehab. Okay, sorry. So what's the role of early intervention? The timing and intensity of rehab matters. Early mobilization, even in the ICU setting, does reach to improve outcome. And functional gains, as some say, in the first 3 to 6 months is dose responsive, meaning you might give few hours more, you might have better outcomes if patient is responsive. And this is where PM&R shines, guys. We are not working alone. We work in a coordinated interdisciplinary care. And this is where we help maximize the outcome in every window of opportunity we can do. So involvement of PM&R early on even helps others, reach the outcome, help others to focus on the outcome goals that we can do. Pharmacological prognostic adjuncts, neurostimulants can accelerate or unmask recovery, especially in traumatic brain injury, amantadine, modafinil, and that's what we mentioned before. Red flags for poor prognosis is prolonged disorder of consciousness, more than 3 months, severe diffuse axonal injury MRI, and repeated secondary insults such as hypertension, hypoxia, seizures, uncontrolled medical complications, infection, and endocrinopathies. Okay, let's talk about what's the evidence and real-life observations, clinical advice. If we're gonna try to help patients understand how we are working and what's the prognosis, we have to address the question: will the patient walk? Will the patient return to work? Will he communicate? And the factors that support favorable long-term prognosis is 1, consistent command following, 2, preservation of sleep-wake cycle, 3, intact brainstem reflexes, early signs of purposeful movement, and the family and the psychosocial support system. We say that patients may show smaller gains where the recovery is mostly in the 12 months. This is how we address it. We say in the first 12 months, we are reassessing the outcomes meticulously. And when we say 12 months, we don't mean that 12 months of admission. We say 12 months from the injury, where an opportunity to help patients does reach a plateau, and we cannot do more, but we do give the same kind of support to the family when they're out of the brain program. Then they are in the brain program with a continuous rehabilitation model. And we have to reassess the patients every 3 to 6 months for goals, not to miss the window for opportunity of improvement. Prognostic models can only give us probabilities of improvement. And be careful when you say this to patients, as families interpret them as certainties. Always use careful language where you give a window and no promises. And whatever models are there, the accuracy of the models have not reached the certainty level. And this is the way that you should or try to speak to families. Frame as these are trends and emphasize uncertainty, and the severe TBI recovery can be rare after 2 years. However, always allow for a prolonged and a window for hope when you say that some gains might happen 3 to 5 years. And keep the word, it's a slow progress journey. We are talking about a slow progress. So in counseling families, use functional anchors such as GOSI, FIM, participation goals, phrase fastest gain in the first year, for example, but progress can continue beyond that, especially in thinking and participation. Highlight individual variability. Avoid giving arbitrary words such as a 1-year cutoff. And we can give you an example of a discussion that we have. For example, we have a 32-year-old patient with severe TBI, and he's 14 months post-injury. He has minimal motor gains, but has improved attention and interaction. Prognosis: is he likely to walk? Knowing that he has a severe brain injury and he has minimal gains and purely has attention and cognition. So we can say unlikely to walk independently, but we might have realistic gains in communication and vocal participation. So try to help families understand that motor functions, as much as it's the cornerstone of improvement to most families, but not to miss the importance of the cognitive, because many patients do walk independently, but they still are a hazard where they're cognitively unaware, or they might be at a behavioral complications that might occur from the injury. So try to not focus on the motor part, and there are multiple other things. So to make it short, use ethics and empathy when trying to convey the message, because we are at the end humans when we give the prognosis. Our role isn't just to predict outcomes, but to guide, support, and adjust expectation over time. And families need clear, consistent updates. And hope must be balanced with realism, and we must remain open to late improvement. Meaning that if I receive a patient, for example, whose injury is after 10 years, one of the most iconic things that we might find is patient after 10 years, does he have the potential to improve? Are there any patients who do not fall into the usual norm? Yes, we do. But when we rely on this, it's mainly heavily on the correct analysis and the correct examination of patients. So what I want to say is, your role as a physiatrist, if you deliver a clear assessment and clear examination and analysis to the patient's current status, we can define whether we can have extra goals. Not any changes that happens after a prolonged prolonged injury has a potential to reach goals. We have to be very careful when we deliver this. And we have to have an open communication when it comes between a hospital where there is a very enthusiastic physiatrist that looks into helping patients reaching the right setting, that he does the first right assessment when he wants to refer the patient for advanced or tertiary care rehab. As we said, we must remain open for late improvements, especially in younger and highly motivated patients. Prognosis is not static, and it evolves, and so should our communication as well. So takeaway message, prognosis is a combination of evidence plus clinical judgment and patient factors. We have to use validated models for context, not destiny. Recovery extends beyond 1 year. Don't prematurely close rehab pathways. And for junior consultants, focus on realistic hope and functional goals. And I thank you so much for this opportunity. And I would like to open discussion. And I leave it to the moderator to go up to the next talk, or we can take questions after Maghrib prayer, inshallah.
I think we have 10 more minutes to Maghrib prayer. So we are good to take question for now. And if we conclude, that's fine. If still you want to continue discussion, we can continue after Maghrib prayer.
I received a question from Dr. Muhammad Thaqafi. How to know that thalamocortical pathway is intact? So there are two methods, which is either we have a structural imaging or a functional imaging, MRI. And the functional imaging, MRI, does provide us with the right information about the thalamocortical pathway, if it's intact or not. When we try to use stimulation, which is tactile stimulation and other kinds of stimulation, we do trigger those thalamocortical pathways to work and see whether they are intact or not. But for the current setting, we do say that in this current setting, when we have a place where there's no functional MRI, we rely on MRIs, basically, and see if the thalamic nuclei are intact or they are affected. Are there any other questions in, for example, another poll? I opened the chat only.
يعطيك العافية دكتور رائد، محاضرة مثرية، جزاك الله خير. عندي أنا بس ملاحظة نفس ملاحظتك بالنسبة للكومبليكيشن مع المرضى اللي مريضين عندنا كانوا، ونفس الشيء مع المثال في نيدات صار لهم كومبليكيشن أكثر من الأمانتادين.
يعطيك العافية. طيب, do you want us to يعني discuss cases, like any case that you want to share, and see whether we can get some second opinion?
Dr. Raed, when a patient we receive patient, for example, in the acute stage, still he has recent let's say.
Yes.
Yeah, usually in KFMC we receive patient a little bit later.
Late.
But in,
Yes.
in peripheral hospital, sometimes they receive patient in acute, still patient within 1 month or still
Yes.
within, let's say, 1 week of the accident or whatever was the cause of his injury. What is the best timing to consider this medication for arousal and improving consciousness?
Honestly, this question is has not been addressed. I mean, not the question, but I mean, how early can we start new stimulant? We have seen cases where the moment that we think that patient does not have risks for developing complications, for example, patient is a pure traumatic brain injury, there are no other comorbidities, there are no secondary infections happening, patient is stable, meaning that he just is in a coma and there is nothing that is causing the coma. 2 weeks from the injury, we can start. But usually, as a guideline, 4 weeks is the safest duration after injury to start the neurostimulant. But have we seen patients who have received neurostimulants from day one? There have never been any recommendations, especially that this is the period where most seizures can break through. And so if we start to put a patient on prophylactic antiepileptic, after that, when we ensure that the prophylactic antiepileptic has been withdrawn gradually, and the antiepileptic does not pose any side effects, we can start the neurostimulant. And there has been only one worry is which neurostimulant, and the only neurostimulant that has been proposed to start at that time is amantadine. And amantadine, to my experience, has not led to a higher risk of seizure, although it is a proposed risk of seizure. We still say there's a proposed risk of seizure, but with careful titration, we might reach the goal. Now, what I mentioned in the presentation today is that we titrate up 3 to 5 days interval, and that is dose related. So if we go from 50 to 100, we might need 3 to 5 days, and so on. So we're not talking about we want to reach 200 milligram BID within 1 week. That is considered very abrupt and dangerous. So we want to be slower. And when we want to talk about what's the duration, we give for 4 weeks and then we reassess and so on. But the moment we have no improvement after 4 weeks of neurostimulation, 4 weeks of neurostimulation, we think that it is time to titrate down. And we can go up to 16 weeks, and 16 weeks is 4 months. And sometimes we can go higher, but all depends on the response of the patient.
Okay, thank you so much. Anyone has any question? If no one has a question, I have another question. We can conclude with this question.
Okay.
So still other thinking, Dr. Raed, again, our colleague received a consultation during acute stage after brain injury. Can you just shed light on what are the things that they can write in their recommendation to acute team or to the surgeon? What are the things they can recommend or to address to avoid the later on complication?
So when you start the assessment, you probably need to make sure that you did your part in the history taking by knowing exactly what was the what are the suspected reasons for the patient's coma, reviewed the medication, made sure you put a list of recommendations on patients with higher sedation effects, putting recommendations on whether antiepileptics needs to be continued or not, and being with patients under neurosurgeons, they might not have a complete hypothalamic pituitary axis hormonal study, meaning the pituitary hormones might be in disruption. And this is one of the reasons why patient is having. Plus, making sure that addressing infections are very important. So when you write recommendations, that please ensure that patients have their infection, whether they're what type of infection, whether it's a CNS infection, UTIs, respiratory tract infections, under management, and with taking into consideration that they have been treated appropriately, you might introduce a neurostimulant when you have cleared all these things. So one of the important aspects of patients' disorder of consciousness is also electrolyte imbalance that might occur, whether it's due to hormonal or non-hormonal reasons. So it is a very important thing to work hand in hand with others when we manage patients. And do recommend, after addressing all these things, you can start a neurostimulant and try as much as possible to give a window for reassessment every week. So every week, if you're going to start a neurostimulant, you probably need to keep the patient on that dose for a whole week and then reassess a week later. Standardize the assessment, make sure that the assessment does have verbal, visual, motor assessments. GCS is one assessment, but other subtle tools such as brainstem reflexes and these assessments are important to put as baseline. So do your neurological assessment clearly, make sure patients' other source of infection has been cleared, and then do a weekly assessment after starting a methylphenidate. All right. This is one question. I don't know if I answered the question, Dr. Muhammad.
Yes. Thank you so much, Dr. Raed.
Right. I have a question from Dr. Abdulaziz. He says that when receiving patients 6 months post-injury, young, no risk factors, has problems with focus and attention span. Great. So plan to start methylphenidate. For how long can we continue and should be tapered for discontinue? The first question is whether we start the methylphenidate. I assume that this patient is in the outpatient setting, or is he in the inpatient setting? The way that the difference between both is our goal. So if he's in an inpatient setting, the goal is to help patient go through the daily activities through the inpatient. We start with a lowest dose possible, and that dose is dependent on the type of methylphenidate we're using. We do have 3 types of methylphenidate: short-acting methylphenidate that requires a BID dose, and we have longer extended action methylphenidate that is usually used once and need to be monitored for the side effects. I presume using methylphenidate as using an ADHD drug. So as long as the patient is showing improvement with minimal side effects, not affecting his function, we can continue on methylphenidate. It is a medication of a jump start, we can say, and we can discontinue the medication usually after a year. And why do you say usually after a year? Is because mostly patients have reserved a good routine, good activity. So We need to replace the methylphenidate with healthy lifestyle, eating, healthy sleep-wake cycle. Patients should be able to sleep in the right time, wake up in the right time. Having a good sleep is very important. Having a lifestyle of activities and improving the gut brain axis. So healthy diet, introducing food that help increase attention. And sometimes these are things beyond today's lecture, is we do find some food that can change the concentration. And most of us use coffee as an example of a neurostimulant. We use coffee to allow ourselves to engage, focus, and then the effect wears off. And sometimes after eating unhealthy food, we have the same effect of dumping or feeling low or unable to focus, and then we think, oh, we need coffee to counteract that. So we have no, to my knowledge, humble knowledge, I don't know how long should we continue or discontinue the medication if there are no abrupt side effects.
Thank you so much, Dr. Raed. Jazakallah khair. Like to أجرك. I'm not sure. There is one question in the chat. You want to have break and continue after Maghrib, Dr. Raed? You want to just answer this question and conclude our session?
We have a question now. Yes.
Just see one question in the chat.
I think I'll be brief, inshallah. Maybe we can conclude if everyone gives a thumbs up. I can, or we can answer this question after the break because it's prayer time coming soon, Yani. I'll go ahead and read the question. Okay, so do you usually consider encephalitis as a brain injury? Yes. When a patient is post HSV encephalitis with this diencephalon and personality changes, what we can do from rehab point of view, and will it be reversible? HSV encephalitis is unfortunately a poor prognosis for recovery in many patients with the likelihood of a change or improvement is very long, and we have no we cannot introduce anything but symptomatic management and not the use of stimulants or medication, because this is exactly what we were talking about, other acquired brain injury. Reversible, I have not seen an HSV reversible or read that it can be reversed, and I could be wrong, but I have not been seen a reversible encephalitis. Have I seen a patient with HSV encephalitis that does not have any deficits? Yes, I did. And usually it matters in the early intervention. The earlier the intervention, the better the outcome. The later the intervention, and we're talking about hours of intervention. We're not talking about days of intervention. So that's what I know. But once the damage is done, it's very hard that they will improve. Unless the diagnosis is wrong. That's another thing. Or there's another diagnosis. Management of agitation post-traumatic brain injury. I think that's a topic.
Dr. Raed, if you mind, yeah, I think there are let's just have a break and come back to see if
خلاص.
because we can take
I'll
15-minute break. I'll be back at 6:20.
Okay.
Would that be
Sure.
fine for you?
Fine, yes. Excellent.
Sure. Plus, we'll be back at 6:20, inshallah, and continue our discussion. Thank you all. إيه تمام.
السلام عليكم. أهلا
السلام
وسهلا.
ورحمة الله وبركاته.
طيب. Okay, what practical measurements can be done for TBI patient in a low rehabilitation service setting? Okay, good question. What is meant by a low rehab service setting? It all depends on your your tools. It all depends on your capabilities and your resources. So when you say low rehabilitation service setting, if you have services, if you have a PT, for example, if you have an OT, and you have a speech, you're not in a low service rehabilitation setting. You probably want to address specific brain injury issues. For example, we are having a patient who is having outpatient case, because usually other rehab services, what is meant is outpatient based, and this is what we would like the TBI patients to have: a safe transfer, assessment, and endorsement in case they need and higher levels to a tertiary care hospital where the full services that can be provided will be provided. And then what the outpatient people work on back when the patient returns back is maintaining the same discharge level, and to make sure that they focus more on community reintegration, because one of the difficult parts of community reintegration is a patient comes from his hometown to a tertiary hospital that is away from his community, and then when he comes back and returns back to his hospital, they don't work on reintegrating him into the community, which is where he's supposed to be on. So I would say these are considered service specific requirements. Now, measurements, practical measurement, you should be able to assess TBI patients' ability to show signs of improvement, whether it's neurological, whether it is cognitive, and whether it is social and psychological, of course. So biopsychosocial improvements are very important. In case, Dr. Jamal, you want to clarify your question more, I'm happy to also answer your question. I have a question. If someone wants to if someone puts a question, then he will be given the mic to be able to clarify the question if in case I did not answer them clearly. Or it's only me and the Q&A.
No, they
Q&A.
can
They can
unmute
do
themselves and answer the
Okay.
speak. Anyone interested?
Okay.
Hello. Hello.
تفضل دكتور جمال.
السلام عليكم.
عليكم السلام.
شكرا يا دكتور على المحاضرة القيمة.
حياك الله.
الحقيقة أنا بعمل حاليا في الصومال في disability center. Sometimes came to me calls in inpatient private hospitals for such case like that. The patient almost came comatose and came from arid area, far from the city town, being more than 2-3 days. And then the hospital itself, there is no specialized in the neurological TB eye cases. And also diagnostic tools are limited also, only CT and MRI. And I have only with me BT not actually graduated. This is only staff as a BTA trained in a crash course to deal with physiotherapy problems in this disability center.
Yes.
And the patient actually in coma more than 1 month maybe or more. And we start to work with him. There is some improvement, but not significant. Even also he have a problem of his spasticity also. In the position of decerbrillator decorticate position. And many complications, even nutrition also, there is a problem. And even also limited drug resources. Very, very crucial situation actually. And we're working about 2 months, start to improve, but not so well now. He respond to stimuli, pain stimuli. He respond to talk as a Glasgow Coma scale is improved, but the musculoskeletal problems are not improved, especially the hand fine movement. Not improved at all. This is the reason. Even we start to sit him in the edge of the bed. We start to sit him from the transfer him from bed to wheelchair and go in the corridor, something like that. But actually, at the end, the family I think traveled with him to India. But after that, I don't know what happened to him actually. So this is why I give you this question.
First of all, I commend you. Thank you very much for giving time to your patients, trying your best to help them improve while in a setting presumed to be an LTC, but a private LTC, so long-term facility looks like.
Yes.
Yeah. So when patients are in an LTC setting, it's more likely that we deal with one important thing. If we don't have resources, we try as much as possible to advocate being handled by resources when our examination allows us. So, for example, I would say you would definitely say he shows quite an improvement, right? The moment they see that a patient has transitioned from a level of one level to another, whether it's FIM or GUSI or any kind of score that you do, it is a chance that you want to push the patient into a tertiary care hospital. The only problem I would think you are facing is the private hospitals demand to keep a patient in the hospital. But then you have the chance to be advocating in way you can to send the patient to another facility where there are services that will help him. So you're working for the sake of the patient as well. This is one part. The other part, which is, I know that you don't have the resources, for example, to do images, but having those information come in hand before, you would probably help clarify the potential to the other tertiary hospital. You would say that, yes, we do receive a patient. This is his image. He's not only a traumatic brain injury, he's a traumatic brain injury with a focal neurological damage on the images, showing a parietal lobe contusion, limited, the diffuse axonal injury. Such cases does help help the other hospitals understand that there must be other things that they can do since the image is not so severe. So we talked about the good prognosticators and the poor prognosticators. So when we understand that good prognosticators are there, and we put that into our referral, then that's where other hospitals' responsibility come in to help the patient and take him. But talking in general is easier than talking specific, and I know that each one of your cases is very specific when it comes to their case. But thank you very much for sharing your question.
Okay, thank you very much for asking.
All right. One very important part that I did not discuss. I'm in this topic that I was talking about. It's my mistake that I did not mention that what I'm talking about is adult specific population. And when we say adult population, that differs from a pediatric population when it comes to TBI. So the pediatric population have their own, their own statistics, their own studies that does not correlate with what I spoke today, and that is a different topic. Pediatric TBI is a different topic. And the use of neurostimulants in pediatric population has no unified protocol, but there have been trials. And since I have not been dealing with pediatric cases, I would not be able to tell you my experience with those stimulants. But in case someone has any experience with pediatric population and a trial of neurostimulants, it will be of great help if the question does come up. I mean, if today or another day.
يعطيك العافية دكتور رايد. Someone asked about agitation before the break time. I know it's a big topic and it's need a lecture in itself. But if you just can give some hints from your practice, which medication you usually use for mild agitation, for moderate agitation, and sometimes for breakthrough agitation, and how much of doses you usually use? Because these things are usually written in general term in our references.
Okay, so since we're not talking about, for example, what are the protocols and what is, and I can speak in short about the experience that I do in management of agitation. Agitation is usually a symptom, and I don't find it as a diagnosis. So it's a symptom of a patient who's having a noxious stimuli affecting his ability to respond to the environment, with disinhibition being part that is not helping the patient control himself. So it is a symptom. Agitation is a symptom. So we can say that a patient is in agitation, for example, if he's in pain, if he's having other noxious stimuli, whether it is auditory, visual, tactile, internal noxious stimuli, external noxious stimuli. We have many stimuli that affects and cause agitation. Internal stimuli is not only every system you can think of, like gut, for example, GI stimuli, constipation. Even patients who are thirsty or hungry, they can go in agitation. Even patients who have headaches can have agitation. So the most important part, before you decide to treat agitation, know whether this agitation is controllable or not controllable. So you can decide if the agitation is because patient is not feeling okay during therapy, then you reduce the therapy time, you change the therapy time, you change the environment. Then you can do something like, for example, ability to treat his agitation in non-pharmacological way. But however, internal continuous dysregularities in patients with, for example, tachycardia due to the internal brain, due to the brain injury itself, then using beta blockers has both the greatest control of agitation, where it reduces the sympathetic outflow. It keeps the patient in a fatigue position. So put in mind, once you start a patient on beta blockers, which is the first line drug, which is the least side effects, because it doesn't work on any neuropsychiatric pathway. It works on the, I would say it works on the sympathetic pathway. Then patient's agitation is reduced. However, this is due to sympathetic outflow. When you talk about a patient who is having pain due to, for example, headache or central nervous system reasons, giving him medications, atypical antipsychotics, helps in management of agitation on a short term and long term, or short duration and longer duration. Medications such as, for example, medications such as quetiapine has the effect on regulating sleep and improving the reducing the side effects of, I would say, the side effects of the agitation. And we can have other examples of medications that doesn't come to my mind, but we do have those. Put in mind, sometimes agitations are due to sleep-wake cycle dysregularities or irregular sleep-wake cycle. So improving sleep by addressing non-pharmacological way may help agitation management. It depends on the patient's level of consciousness. Depends on whether he is in a Rancho Sos Amigos 3, 4, 5, or 6, or 8. Each medication can be started based on the experience, and there's no, there are a couple of guidelines what you start with and what's the next, but make sure that you know the patient before you start any medication. Because the worst thing you can do is medicate patients because you don't have time to address all his issues. You don't have the resources to look up the reason why he's agitated, or because of, I would say, laziness when it comes to trying your best to help the patient non-pharmacologically treat his agitation. I think this is basically what everyone goes through when he goes through the board exam. He might memorize the management of agitation, and this is the safest way you need to have. You need to know exactly what's the pharmacological, non-pharmacological modalities to manage patients. But when it comes to real life experience, not all medications can treat agitation or are safe to treat agitation. And there's a lot of trial and error when you start medications. But don't skip beta blockers unless there is a contraindication to give beta blockers. And there are many contraindications in patients with anoxic brain injury. For example, most of these patients have history of cardiac arrest, and they would not be eligible for beta blockers, for example, although they would respond well to beta blockers, but you need to address it with the cardiologist or other doctors. It might not be the most suitable. Beta blockers side effects include fatigue. It includes weakness. It includes sometimes somnolence, not because of a central reason, but because of a peripheral reason. Patients feel like they're sleepy. They're just fatigued. And don't forget that patients also might have drug-drug interactions with beta blockers. And the topic is big, and I think there will be an opportunity to speak about it in a later presentation. I'm happy to present it one day.
Thank you so much, Dr. Raed. الله يجزاك خير كتب أجرك يا رب.
What about using TCMs in TBI cases? Can you clarify TCM abbreviation, Dr. Jamal?
Transcranial magnetic field.
Okay, so TMS, transcranial magnetic stimulation. Okay. In non-invasive brain stimulation have risen into interest, and this was not recent. It took maybe started since the mid-80s and so forth. The use of transcranial magnetic stimulation in in recovery has been studied in cases of post-TBI, post-stroke depression, post-TBI, post-stroke aphasia, but stroke more than TBI, and in some cases, motor recovery. There are still papers about it, and the use is both, I would say, safe. Transcranial magnetic stimulation is not a hazard, or has not been proposed as a high risk for complications unless it is not being done in the right protocol. So handling the transcranial magnetic stimulation without proper training is the problem, which we can say that some hospitals might have the trend of adopting the transcranial magnetic stimulation without training, proper training and proper protocol. What I mean by training is not that how to handle the probe, or the magnetic stimulation probe and the coils, but also the intensity, because sometimes a super intense dose has different effect. Plus, a lot of education needs to be given to the patient and the family about what is expected from that stimulation, because it is considered a very an abnormal sensation, where there's a stimulation that occurs involuntarily without the patient's expectation. It's exactly like you're trying to do a nerve conduction study without the without giving education about to the patient that you might feel sting. Transcranial magnetic stimulation does not cause pain or has the same effect, but it does have the feeling of jerky movements is need to be, patient need to adjust to it a little bit. And they might feel different because post-brain injury is different. We might stimulate other places. We might not find the effect. You need to be very wary about how to start, how to taper, when to stop, these kind of things. Now, transcranial direct stimulation is different. Transcranial direct stimulation is usually safer because it does not go to the deep structures, and it has lesser side effects, lesser chances of patients developing seizure. Although TDS works on the cortex, if done in the right population where there is no risk of seizure, or not stimulating a highly, I would say, a highly susceptible area for seizures, you can do it. We can TDCS. I don't think that it's it can be done much easily than TMSs in anywhere. Okay, the next question, please. What is the best medication for spasticity with traumatic brain injury? This question is so important, so simple, but there is no simple answer to it. We can say that there are medications that does not have secondary CNS effects. There are medications that work peripherally, but throughout the cases, most cases of brain injury have generalized spasticity, where the use of Botox is very limited, and the use of medication that doesn't work on GABA receptors have lesser effect. For example, patients who are on tizanidine or dantrolene do have lesser spasticity management than those patients on baclofen. But when we come to the reason why we're changing or starting the patient on spasticity medication, we have to have a rational reason. Why are we starting a patient on dantrolene and not baclofen? Is it because of the side effects of the baclofen? Is it because we always are thinking about the risk of the baclofen decreasing the threshold of seizures? What's the reason why we're changing it? So I can't, and by the way, dantrolene is not a safe drug to keep the patient on for a long duration. There are many situations where patients have higher risk of fall when on dantrolene than other medications because of the way it affects, because of the axial spasticity control that it elicits. It's not that easy to recommend something. What you need to do is make sure that the patient is not having higher doses than needed of any medication. And once you can manage focal spasticity, do so, even if patient is on oral medications. So other benzodiazepines have been proposed, but most medications for spasticity management having central nervous system, CNS involvement and affection does not help cognitive recovery. So you need to balance. In brain injury, you need to, go one goal and work on it, then change your goal if you can. That's why treating brain injury is not a period of 3 months of intensive inpatient rehab and then you solved everything. In some cases, and then sometimes the recovery, their goals change over years, not only months, but years.
Thank you so much, Dr. Raed. Anyone has any other question? I think we're about to finish our meeting, almost 2 hours.
I must say something. Really, I'm more glad that you gave me the opportunity to talk than anything. Really, I'm honored that I was able to give you a little bit of what I know, and I know nothing so far of what is a brain injury. This is a very wide, diverse, various result of research and a lot of things that the complication of brain injury is not easy to comprehend. And I believe every one of us who are dealing with a brain injury patient is a brain injury specialist if he gives his time and effort to help his patient. And what we can do is collaborate together to be able to change our practice from time to time. And please try to be updated when it comes to the the future changes that we have in our future in the career. Make sure PM&R are at they must be and should continue to be the cornerstone of rehab services, coordination, and intervention. So please try your best to add to your skills, whether it is TDS, for example. You can be a PM&R that does transcranial magnetic stimulation. You can be a PM&R that does other kind of stimulation, because these skills do help us and help our career. And we all need each other to advance. These are things we can use them as tools to help our patients as well. So this is my take-home message. And thank you all.
Thank you so much, Dr. Raed. Appreciate your time and effort and your wonderful, amazing, and interesting lectures. Jazakumullah khair. Tomorrow we'll have rest, inshallah, and we'll be back on Saturday at 7 p.m. with Dr. Ayman to discuss, inshallah, practical tips for neuro rehabilitation field. Stay soon, enjoy your weekend, and see you, inshallah, on Saturday. Assalamu alaikum.